Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
Welcome to the Quorum Conversations. This is the August session where we were going to do burns and sepsis, but Bill had a very clever input of let's split those out. So we'll do burns this month and do sepsis next month. So this is based off of CPGs from the joint trauma system. And basically, I broke down all of the CPGs into the prolonged field care algorithm. And this is what we're working off of. Working through the March, pause, Hittman algorithm. On the left side is CABCDEFGH from the college. And on the right is March, pause, and we add Hittman to the end of that. And we are now down to C circulation, and that's burns. And next month will be C circulation, which is also sepsis. So this is where we are. Starting at the top, Bill.
Welcome, everyone. By show of hands in the chat, how many have actually taken care of a burn patient? Just kind of raise your hand in there. As we go through these bullet points, we're gonna focus on the so what. Like, here's what the CPG is. We've all read the CPG, or at least we've scanned through it and we've looked at it and we treat these patients. The goal of this conversation and the reason why we separated out burns and sepsis is so we can spend a little bit more time conversing about this. Now, burns are incredibly complicated. They're complex patients. So they have quite a few idiosyncrasies that go on. And so the goal of this talk is to have those deeper conversations about how do you manage airway and how do you manage pain? How do you assess burn size and all of those things? Because we've got a lot of experience in the chat and we want to be able to share that so that we all collectively get smarter on this topic. So that's the main goal. So a lot of this keys on your input. So when we're looking at burns, we're obviously concerned about an airway, whether that's something that's going to happen secondary to the resuscitation effort with that third spacing and swelling, or it's going to be a deteriorating patient, or the fact that they got an inhalation and their airway is going to close up due to that reason. So all of those things, the CPG focuses on, and we'll go from the bottom up minimum. So in our environment, in that remote and austere environment, a crike is the easiest of the two, that versus the other one being rapid sequence intubation, which requires a little bit more. So those are not free procedures. It takes an effort, it takes training, it takes planning to do a good, successful crike on a patient. Well, so if you decide to do a crike on a patient, you can have your kit set up and you've pre-planned it, you've pre-packaged it, or you have a kit that you purchased. Be familiar with where everything is in that kit. So you understand when you open it up, that's not the first time when you have a patient that needs a crike in front of you. That would be horrible. We need to train definitely more to this, but be comfortable where things are and figure out how can I successfully complete this task, this procedure, if I drop something, if I don't have something in my kit or it was used for something else. Like, you need to come up with a pace plan for when you're doing this procedure. A lot of times the appropriate thing is to watch and wait. Now, you're going to have reasons to do this procedure, but criking somebody is not a free procedure, meaning it's going to require more hands-on and first-hand monitoring when you do a procedure like that. You can't just walk away and treat the other 20 patients in those situations. So managing an individual patient's airway has to figure in what you're doing in the rest of the triage that's going on, depending on, an isolated individual injury or a group trauma triage type scenario. Definitely, if you're going to secure somebody's airway definitively, you're going to have a bag valve mask and a PEEP valve, and you're going to, ideally give them some type of sedation if you can beforehand, or ongoing management based on the totality of their other injury.
Can I do a quick jump in, Bill?
Absolutely.
We've got a hell of a cross section of folks here tonight. I'm just very interested how many on tonight's conversation have carried out a crike in the field. You get a thumbs up or a thumbs down? Just a rough indication how many people have done a crike in the field.
Yeah, we've got a few.
Yeah.
I think doing a lot of them in training gives somewhat of an idea, but a real patient is another level of pucker factor.
Absolutely. Interesting. Cheers, folks. Thank you for that.
Yeah. So you can do an awake crike. I have not done an awake crike. I've done a sedated crike. You definitely want to, if you can, communicate with your patient what you're about to do. You're going to do that verbally, But also non-verbally, you're going to have to kind of keep a poker face, because if they see the fear of God in your eye as you go to sleep before you do this procedure, so that's a whole nother level of stress that you're introducing to the patient. Anytime you're going to do this procedure, part of the prepping of what you're going to do, your mismade, is to set up all of your suction, maintaining your sedation plan, whether that's ketamine or something else. Have oxygen as you move higher up on the scale here to the best. You'd like to have oxygen or a ventilator or managing airway device. Whether you do that interval dosing, pulse dosing for sedation, or you do continuous IV sedation, that's a choice too. All of that goes into your plan. Are there any questions on airway management? Once again, designed more to be a discussion about complications and concerns or questions more than a just blistering pace of running through bullet comments. So the so what of the airway is you want to protect and secure the airway and avoid obstructions, whether that's from the burn, from the resuscitation, or from any other concomitant trauma that patient has. All right. Right out of the pocket, how do you assess a burn size? So rule of nines is what we're taught. If you look in the CPG, it talks about a Lund-Browder chart that you can reassess later. I've never personally used that. I look at that, and from a position of being in a remote and austere environment, I don't know if I would ever dig that deep into it, but the chart is in the CPG, so we're going to address it. Has anybody in the group used or referenced that Lund-Browder table to estimate a burn size? I have not. I think it's good information, as all medicine and information and how things are put out there. I think that it's a good reference chart, but as the provider that's in the remote and austere environment, I would go and keep it as simple as possible. And that's going to be my rule of nines. Any other feedback or techniques that people use?
Lund-Browder is the one that's just drawn out diagrams with people with percentages, right?
No, it's a graph. Hit it or deleted it. It's a really busy graph. It's on page 13 of the CPG, Appendix B. And it's a list of the areas on the body from head, neck, anterior trauma, posterior trauma, right buttock, left buttock. It really breaks it down. And then it breaks it down by age. So birth to 1 year, 1 to 4 years, 5 to 9, 10 to 14, and then 15 years, and then adult. And then it has a separate column for second and third degree burn. So it is a very comprehensive chart to calculate your second and third degree burns. And it is a documentation tool. Good point, Cole. But if you're adjusting your fluid resuscitation levels, which we'll get to in a slide or two, it's all based off of your TBSA. So you need to have a pretty accurate TBSA. But once again, this is more of a science, more of an art than a science when you're managing the fluid resuscitation in a burn patient, because everyone's going to be a little different. You're going to have different ways of doing this. Are you going to let your flow go into gravity? Or are you going to use an infuser? Or are you going to use pressure? Like, how are you going to administer this fluid to your patient? Are you going to do oral rehydration? So all of those things that moves it from the complicated column to complex. There's 3 columns in medicine. There's simple tasks, complicated tasks, and complex. Burns, it's made up of a lot of simple things like starting an IV or watching an airway or having suction and prepping all your equipment. Then you get into complicated, where you're putting IVs and fluids through burns. You can do that through burns. You can put an IO through a burn. You can start an IV through burn. Now, those are things that becomes more complicated based on the obstacles that you have. And then complex is managing your fluid resuscitation, your airway management, your pain control, your sedation, and all of those things in a patient that's pretty traumatized with burn, completely aside from them having additional trauma and secondary injuries. So there's 2 layman's terms. One is the rule of nines based on the extremities and the torso. And then if it's smaller burns, you can use the patient's hand size, which counts for approximately 1% of TBSA, right? And then as you come up, you do your rule of nines for best. Then after you clean and debride all the wounds, you get a better look at the body surface area, and then you can do a better assessment to use the more detailed documented charting of the Lund-Browder estimation. The goal is you want to be as accurate as possible so you can estimate the amount of fluid that you're going to use to resuscitate accurately, right? Any questions or comments on the burn size? Okay. Next.
Rhod, you mentioned using an app. So does anyone use apps to kind of tap out the burn on the casualty and then calculate it from there? All right.
I think I'm a fan of technology, but it's something that you need to be comfortable and familiar with. Even if you're using a drug reference, like, Hippocrates or Medscape or UpToDate, you have to be comfortable using that device when you're stressed, not when you're sitting around, kind of chilling out on the couch. So those are things to consider. All right, resuscitating. This is a really basic one here. Starting the fluid rate at 500 cc's an hour. Has anybody done the math? And do you have a cheat sheet in your kit to say what the flow rate based on the drip admin set that you use? Do you use a 10 drop, a 15 drop, a 20 drop, a 60, whatever? And so what is that drip rate to get to 500 cc's an hour? Like that's going to be a difficult thing. Like if you haven't calculated out what 500 cc's an hour looks like using a 10 or a 15 or 20 drop admin set, that's something that you should have. And build a cheat sheet. There's a pretty good formula that you can use. You can use apps, flow rate apps to tell you what, what's the latest one that I'm using? IV drop, and you could basically put how much fluid you want to do it, what admin set over what time, and it'll tell you how many drops per minute. Some of them will give you a visual representation of what that drop should look like. So on the app, it'll show drops, and then you basically match the drop in the drip chamber to what the app is showing.
Is that the one where you use a camera and the camera calculates it?
No, the one that I had is where it'll show the IV admin set and you could tap it. Like if I'm watching the drip chamber drip and every time it drips, I tap my screen. If I just do that, and then at some point when it says, all right, this is consistent, or here's the amount, it'll tell me, all right, your flow rate is X number of drops a minute. It's pretty cool. It's better than counting for a whole minute. It's estimate. And that's if the flow rate is consistent. The other part too is if you say, hey, I want to drop at, 25 drops a minute. It'll show an animation of a drop that'll drop 25 times a minute. And then all you do is as you adjust the flow rate in the drip chamber, you just match the drips in the drip chamber to the picture on the app. And as each one drops, you just time it so it's the same. It's pretty interactive. Yeah, and those are free. Andre, you got a question?
Yes, I just wanted to add that there is this formula to calculate actually the drip rate. Was told it would be like volume in milliliters we want to administer divided by minutes, time in minutes, and multiplied by the drip factor. So whether it's 20, 60, or depends what we have. So that will give us how many drops per minute.
Yeah. No, it's good. Whatever, there's formulas out there to be able to do it. I recommend having a cheat sheet with the admin set calculating your medication drip rates for drug calc, and then have one for flow rate, and then be able to, the blank formula. You just write the numbers in with grease pencil, alcohol pen, whatever it is that you're using, or even, a white marker, marker on a whiteboard or a chalkboard or piece of paper, just so you're able to do it, but have a blank format that they can just plug in the numbers. I have to give 500 cc's in 1 hour. I have a 10 drop admin set, and then time. And so you just have those three calculations, and then you run across the board, and it'll tell you how many drops per minute that you're supposed to do. Or you could do all that math now and just know that if I have a 10 drop admin set to give 500 cc's an hour, that's going to be how many drops per minute. And, put that in your cheat sheet. Like burn is complicated. You want to simplify. And, if the CPG tells you to start your fluid administration at 500 cc's an hour, what is that drip rate based on the drip set that you carry? Like you should know. Like I'm not going to say it off the top of my head because I haven't done the math before this, but that's something that if I were going to go and manage a patient and I had 15 drop admin sets, I would know what the drip rate is for 500. Like I would pre-calculate that. It says as a minimum, you can supplement oral. If your patient can drink, if they can secure their own airway, or their burns aren't severe enough, you could have them drink orally and just document that. And that's, part of that is when we get into monitoring a patient, they talk about monitoring the eyes and O's and the vital signs when you're training that. But you can do this. And if your patient is unconscious and they're not able to drink and you can't get a line, you can do rectal infusion if that's the case too, right? If you don't have IV fluids, you just have a solution, an electrolyte solution that you've mixed up based on the improvised formulas out of the World Health Organization and all the other facilities out there, then you can infuse that fluid rectally if you don't have an NG tube to put down your patient, right? There's things that you can do to get fluid in there, because the idea and the so what of this is you're replacing all that lost plasma from the burn, and you're trying to do it over a 24 to 48 hour period. Why do we want to avoid plain water? The main reason is to avoid hyponatremia. Now, hyponatremia is the initial complication of using plain water because of the osmotic effect of that. driving fluid into the third spacings and complicating all of your other, your like airway and all your other circulation issues. When you're administering this, once you start your fluid rate at 500 cc's an hour and you do your total body surface estimate, then you can use the field one, which is the rule of tens, and it's your total body surface area times 10, and that's your flow rate for that first hour. And then there's a caveat to it for heavier patients that are over 80 kilograms, you're going to give an extra 100 cc's or mLs of water, of fluid, for each 10 kilograms over the 80, right? I've seen people get a little kind of esoteric on this. And if you have an 85 kilogram patient, do you kind of calculate and add 50 to it or whatever? There's tons of ways to give fluid resuscitation. There's so many different formula calculations out there that it is an art. There's a science behind it, but it is an art to manage this.
Well, what are you saying? The flow rate or the total amount per hour?
The total amount per hour. Yeah, sorry. Good catch. Yeah,
this
so
is a lot more than this is a lot more than Parkland's, like significant.
It's initial, right? That's going to be your initial. You're going to start off giving that's your flow rate per hour, and then you're going to calculate the total based on whatever formula. Now, what I recommend is as soon as you have a complicated patient, reach out to a burn center or reach out to telemedicine and talk to somebody. Ideally, wherever you're going to send this patient, you talk to them and you talk to the receiving provider and you go, what formula do you want me to use? Right? Without having that information, you have your starting it at 500 cc's an hour, doing your rule of nines to estimate total body surface area, and then you rule of tens to calculate the amount of fluid you have to give to fine tune it to your patient and their injuries, right? And then you're going to get started on that. Then you're going to call telemedicine to whoever's going to receive this patient, and you're going to go, what formula do you want? Because if you start off with, and I'm just going to be generic, if you start off with resuscitation formula alpha and you get to them and they like Zulu for some reason, then they're going to question everything else you've done, right? Especially if there's a complication. Caveat, there's always a complication with a burn patient in fluid resuscitation. So bottom line is find out what formula they like and just adapt to that formula, because one, that's going to get you in tune to the receiving provider and what they want. And it's going to make communication back and forth and making adjustments a lot better because you're speaking the same language using the same formula. So simplify this as much as possible when you're in a situation where simplicity is a bonus.
It's probably worth mentioning as well at this point, Bill, isn't it, that we're doing that initial resuscitation. The longer we're holding this person, then we're going to start getting into our measuring unit output, which might answer, question about adjusting then our flow rates. So we're not going to be absolute with our calculated algorithms once we're in a position to start measuring that urine output and going for that 30 to 50 mils per hour.
Yeah, that's so the next slide is on monitoring. But that's all of this stuff it's really hard to have a linear conversation because it is such a dynamic process. And so we're just kind of going to go through this linearly, but we're going to be jumping back and forth because a lot of things are interactive. That's what makes a burn patient complex, right? So they obviously want isotonic crystalloids to reduce the osmotic effect of fluid moving back and forth and lactated ringers. But if all you have is normal saline, what are you going to give? If you have to give enteric versus parenteral, if you have to give IV fluids, what are you going to give? That you're going to call that receiving provider. You're going to say, this is the only fluid I have. And then what other monitoring essentials or tools do you have to monitor that patient? Right now it's become more complex because you're limited in what supplies you have based on where you are. And so that may lead you to do more of the modified electrolyte solution to put together and give that orally or rectally, right? All of that is in communication with the provider that you're going to be handing this patient off to, or at least they're going to be consulting with you in the management if evacuation is delayed, when evacuation is delayed, right? So be open to variations to this. And a lot of that will stem from communicating with whichever receiving or consulting provider you're dealing with. The next slide.
One more thing on fluid resuscitation. Last summer I was teaching Swedish Soft, and we had our head of our PhD department there, and she had a bit of a conniption on this minimum, better, best. She went to Oxford, so I think she knows what she's on about. She said minimum, better, best is bollocks because the best rehydration is oral. We need to change this. Oral rehydration in an austere environment should be the best, not the minimum. We should aim for oral. Her point was, if they can drink, why are we using, and you can get your urine output, like Rhod said, and why are we burning through IV solutions that we only have 2 or 3 bags worth? Mason?
Yeah, I completely agree with that. And the other thing that I've been pushing for at my hospital is, like, I feel that there's this desire among people to use IV meds, but if you have oral bioavailability, there's less complications, less cost, and less size. Like, if you can do oral meds and oral fluid, both of them are better than IV, unless you absolutely need the extra half hour onset speed of IV. But most antibiotics, for example, oral works just as well as IV.
I agree with both comments. Here's my question. Why is oral better than IV resuscitation? Do we understand that?
I mean, I think it's like the simplicity of it, right? You can just have drinkable fluid rather than sterile fluid. And there's less complications to the line. It's easier to move the patient when they don't have something dragging out of them. So, like, all around, it's like the more simple way to go about it with less complexity and less complications.
Don't forget. So, we had a hand raised. Mason, you're right. But let's look at this even more pathophysiologically. Third spacing is just not going to be the same problem. We're not going to have wet lungs by superhydrating. And we've all seen burned patients, and we've thrown, back in the 90s, we threw 2 liters of saline to everybody. They sneezed, they got 2 liters. So by using Ella's point of using oral first, we just bypass all that problem.
So then in that situation, you have to be aware of the complications. So if it's an airway patient or the burns are severe, then that oral option, you're going to have to be modified, meaning NG tube, orogastric tube, something to put that in there, and then positioning of the patient, and then the volume. 500 mLs an hour is just 1/2 liter bottle of water that you can modify the solution, using the modified electrolyte solution. So that's it. So having the complications, if airway is not an issue, if sedation is an issue and they're not awake, that's another thing. But I agree, orally is very simple. It is less complicated, and it uses the body's normal system, as long as that system isn't completely shut down by other concomitant injuries, right? So you have to look at all of those factors. So logistically, it's probably the easiest. Technologically, it's the easiest, but this is a complex patient, so you have to look at all the other dynamic factors and take it in. So I think it's a good point to consider, and I like simple.
Vio, go ahead.
Yeah, I was just thinking about this, and we also need to, in my opinion, take into account the rate of absorption. So if you have a patient in shock, then the rate of absorption is a bit different. So I think that the routes we need to consider, and we need to consider it depending on the patient's state.
Valid point. So the oral rehydration maximum is 1 liter, and that's not 1 liter at once. That's 250 mils every 15 minutes. And anything over that, you're going to pee clear, and you're going to think, like my drill sergeant did in the late 80s, that you're hydrated, but you're not. So maximum of 1 liter per hour, but sipping.
Well, a lot of that goes to compliance too. That's the coached drinking. So based on the volume that you want, do they drink a whole 500 cc bottle of water in 1 gulp and then sit around and do nothing for an hour? Like, what's you have to coach them through optimal resuscitation and how they're consuming that amount. No, good comments.
Cool.
Monitor.
I'll move on to the next.
So the what on this is you're trending all the vital signs and everything you're giving the patient and what's coming out. So if that's the case, you need to be able to use a blood pressure cuff, stethoscope, pulse oximetry, and then document everything using the flow sheet. Whatever flow sheet is, even if it's just something on the wall, right? There's tons of flow sheets out there that work. PFC's got a flow sheet that's been modified, and it's great. Definitely fill that out. Accuracy is important on that. Capnography, when you get in there for in addition to the pulse oximetry, if you're controlling an airway, and then obviously up to something that works to provide continuous monitoring with display and a history of the patient's vital signs is obviously in good monitoring. The question I want to ask is, what does frequently mean? What does frequently mean, and how do you adjust that frequency? Like, what is your go-to frequency, and how long do you sustain that? Why do you change? Any comments? So obviously, yes, depending on the patient status. Sometimes you'll see charts. I think in the original one here was how often? Aebhric, what did you put in there? Every 5 or 15 minutes?
Every 15 minutes, you drink 250 mils of fluid.
No. I'm talking about the monitoring. Like, how often do you check vital signs? If you're doing the manual, if you're a novice doing a full set of vital signs takes a minimum of 5 minutes. We just see that in training all the time. Non-medics collecting vital signs and doing it. They're running the full cycle is about every 5 minutes to do a full set of vital signs. And if you're running it every 5 minutes, well, they're never not doing vital signs. If you have an
that's why the CPRO vital signs, those 4 basic ones, are instantaneous to get. And we can get those every 5 minutes on a critical casualty. But you're right. You got the 18 Bravo there just doing vital signs the whole time. He's going to walk away. He's not going to be happy doing that.
Yeah. So I think part of it is figuring it out. What makes the most sense? So if you're measuring urine output, go ahead, Tanga.
I was gonna get you to finish and then.
Yeah. No, I was going to say is as you're monitoring, if you've got your patient on a flow, like say, I want you to drink, put a line on a bottle, and I want you to drink this much, in the next 15 minutes or this much in the next 30 minutes, you're going to do your vital signs kind of in tune with metrics that you want the patient to follow for his consumption of fluids. And that way you're sitting there talking to them, you're confirming that they're actually consuming the fluids, not just pour it in their mouth and spitting it out or something, because you can drink so much for so long and then your patients are going to get non-compliant just because of the monotony of that's how they're getting their fluid. They may or may not appreciate the need for the volume that you have them consuming. Questions on the vital signs? Tanga.
So I've been thinking about this a little bit more often lately and talking about continual assessment and treatment of multiple patients. And Aebhric just gave me a bit of an idea of, I'm so used to, especially in the civilian, like ambulance setting, having everything on everyone because that's my only patient. I literally don't take my eyes off the patient until I transfer care. I'm trying to develop a bit better of an approach to multiple patients and continuous assessment and not just having one set of vitals and just assume no deterioration. And I do kind of like this idea that Aebhric was talking about having the CPRO as baseline and maybe doing that one every 5 minutes. And then based on severity, maybe adding a blood pressure every 15 minutes to the patient who's more severe. And then maybe every 30 minutes to the patient who's less severe. And I haven't really ever thought about it like that before. I don't know if there's any approaches you guys have found success in, especially when we're talking about manual and not enough blood, a vital sign equipment to leave on people.
Aebhric, do you want to initially comment on that?
Yeah. So we created this in the college ages ago, and so BP is and MAP is everything as a critical care paramedic. Everything is about MAP and urine output. We get that. But the CPRO is instantaneous. You got a SpO2 on them, so you can immediately see their oximetry rate and their pulse rate, and you can trend that over 5 minutes and getting their breathing rate. Come on, we've all been doing this well. I can look at somebody and get breathing rate in 2-3 seconds immediately. I mean, so CPRO is just quick, and that's going to give us hemodynamic statics very quickly. And then we need that MAP as well. So that will be part of the BEAST, the secondary vital signs of BEAST, B being BP. That can happen well as needed, or every 15 minutes. Set your watch. Boom! I need the BEAST vital signs because it's been 15 minutes.
Mason.
Yeah. So I was actually just thinking about this recently with the CPRO. There are newer pulse oximetry probes that also show the rest rate and a pulsatility index. So cap refill is to some degree, related to the pulsatility index. So you can almost use one of these newer SAP probes and have all of your indexes like just showing on it in real time and at any time with no effort. If you can kind of translate the pulsatility index to the cap refill in terms of how well they're perfusing peripherally.
Nice.
That's a good point. Via, do you have another question?
It was more like an observation. It's also depending on what equipment we have in the field. From my point of view, because I've been on vessels that didn't even have a monitor, so I'm lucky if I have a monitor, get an MRX or a LifeLac 15 or whatever, and that can give me loads of information. I think that the monitoring can be subject also to the level of the equipment. So in an ambulance, you have loads of equipment.
So the maximal pulse oximeter, it has the ability to offload the data onto an app on a phone.
Okay.
And you can have more than one pulse oximeter connected at the same time. And you can do all that simultaneously. So it's quite a clever gadget.
Yeah, I've seen those at conferences, and they connect into the medic tool, which we use a bit in the college. And you can have a whole clinic full of people using that Massimo device, and then it remotes into your iPad. So yeah, they're getting better and better, aren't they?
Yeah, absolutely. Yeah, I mean, it's out there. I mean, if you haven't got one, you haven't got one. But if you have, it's a useful tool.
Yeah, I think anything that does continuous monitoring of one or more than multiple patients, then that actually makes it easier. If I don't have any monitoring devices to continuously monitor them, I will prioritize what I check and how frequently I check it based on the problem. So if they are having increased work of breathing, then I get all of the vital signs that are associated with that, meaning their pulse oximetry, their capnography, and then their rate. And so those are the things that I will prioritize. If they don't have a respiratory problem and it's just a fluid resuscitation, well, then I'll check their pulse, their cap refill, and their blood pressure. And then if I don't see that they're working or breathing, then I don't care about counting respirations because they don't have a respiratory problem at this moment, meaning there's no work of breathing and it's difficult for me to count their respirations. If they're breathing really fast, that makes it easier to count. And so there's a respiratory issue going on that they're breathing so that you can easily see their respiratory effort. If we're just sitting here looking and I'm watching Aebhric and I can't really tell how many times he's breathing because there's no work associated with it. It's just everything is flow and it's easy. So I think all of that goes into prioritizing what you're going to monitor when you don't have a way to continuously monitor vital signs on a patient. You should prioritize what you're looking for based on that injury and that specific patient. I think that's a way for you to fine tune when you have to prioritize a bunch of tasks. And if you have more than one patient, it'll help you from doing, yes, it's nice to do the same thing on every patient, but when you have limited time, you have to start priorities and changing things. Who had their hand up?
Tanguy.
Has anyone had success in teaching their patients to just trend their own vitals and tell you when they're worsening? I mean, if we're talking about giving everyone a pulse ox, then just saying, hey, if you tell me when that is below 90%, or, if your heart rate gets above 100, has anyone tried that? I'm just curious.
It's not a bad idea. I've involved the patient in what's going on with them and having them give me updates. If anything, it would be more buddy aid where I have, somebody sitting next to and say, hey, you look at him and let me know. Because if I'm really worried that their pulse ox is going to drop below a certain percentage, well, then they're probably, their level of consciousness may not be where I want it. And so I would have an assistant, somebody watching them. The problem with having a bad patient trying to tell you when things are bad, the only way they can tell you sometimes is by not responding and going to sleep kind of thing. So yeah, but no, it's an interesting idea, but definitely involving the patient in their care, I think has a positive effect on things because they're paying attention. You're less likely to miss some simple things. Yeah. Who had a question? Bio?
It also forms part of the psychological care of the patient. If they feel they've got an element of control over their own condition, self-empowerment goes a long way to aiding the entire recovery process.
That's in that positive outcomes from involving the patient. Yeah, absolutely.
Well, you need to, as Mr. Jordan pointed out, the patient also needs to be in the right state of mind. I tried this with a patient on a rig. Initially, he told me that, doc, I got 170 pulse on my watch, and I think I had a cardiac arrest. And then, when I hooked him up to the monitor, his pulse was normal, like 50 something. He was an athlete as well. Mm-hmm. As soon as he saw that it went to 60, again, started to panic, pulse went to 90. So it just depends on what type of patient you have. I'm sorry. This is, a bit not cool.
You get your hypochondriacs and you get your stoics. I've been on teams with both where you got to walk up to the one guy every day and tell him today's not the day you're going to die. You're going to be okay. And then the other one you have to catch when he makes a slight grimace when he gets out of a chair, and you got to talk to him when no one else is around. So yeah, personality plays a huge factor in that. Good point. Aebhric, you want to go to urine output? So this one is pretty straightforward. Your goal is 30 to 50 mLs per hour. That's actually a calculation. It's 0.5 to 1 cc's or mLs per hour per kilogram on your patient. So when you say, 30 cc's out of a patient, if you've got a 110 kilogram patient, 30 cc's is not sufficient. Like 50 is the minimum that you want on something like that. You have a larger patient, should get a larger volume, which will match the larger requirements for fluids that they get. So the 30 to 50 is a good textbook quick answer, but that's calculated on their body weight. in kilograms. This is interesting. I haven't read it in a while, and it brought me a reminder on this. If you don't have a way to measure urine output, then you just basically keep it to the heart rate of less than 140. And I think I would like to read a little more on how they chose that. Obviously, you got a shock index where the heart rate and the systolic should be in the appropriate locations, where your systolic blood pressure should be higher than your heart rate to be less than a shock index of 1. Curious as to how they came up with the less than 140. If anybody knows off the top of their head, that's great. I may just have to reach out to Doug or some of the guys that wrote it and see what they were thinking. I definitely like the good cap refill because that's a quick one. And then mental status, and that goes back to the kind of neuro and disability talk that we had, where if you're conversing with your patient, are they responding appropriately and timely and accurately? Those are important things to determine mental status. And obviously, if you can get a Foley, put a Foley in. It's better to measure your output. And then adjusting your rate. Here's the art of it. There's a science behind it, but the art is if your urine output is too much, then you want to decrease the rate that you're flowing by 25%. And to kind of target that 30 to 50 cc's an hour. And that's the art of this. You kind of going to do some adjusting depending on how your patient's consuming the fluids. If they're doing it orally, how you're administering it rectally, and whether you have a sufficient amount to do it through intravenous. And then the comment on the 180 mLs over 6 hours is adequate. So if you have an initial trauma patient and you start fluid resuscitation, your fluid rate and your urine output may not be, it's going to take some time to respond. So your first couple hours may be sub 30, and then you'll get later on where your flow rate, because you've increased it 25%, over time, the rate, then your fluid might become greater than 50 mLs. And so what they're saying is an average of 180 mLs, or a total of 180 mLs over 6 hours averages out to 30. And so that totality of a certain block period for 4 to 6 hours is a good way to estimate the appropriate resuscitation or successful resuscitation. Any comments or questions on this, Rhod? Yeah, Dimitro.
Yeah, I got a question regarding the urine output goal. So for me personally, that is the main indicator of the resuscitation adequacy. And in different resources, as you mentioned, that 30 to 50 milliliter per hour, that is our goal. But for some patients, it's not enough. And some patients, they're overloaded. In some resources, we can find that the goal is 1 milliliter per kilogram per hour. And I found that most of my patients getting that amount of fluids, they are overloaded. And then recently, I just found in prolonged field care recommendations regarding the sepsis management that they say that urine output higher than 0.5 milliliter per kilogram per hour indicates over-resuscitation. So my question is, don't you think that for accuracy calculation of urine output is better to use 0.3 to 0.5 milliliter per kilogram per hour, and then we can measure our urine output based on the patient's weight, and that it will be much more accurate than we say just 30 to 50 milliliter per hour?
I hadn't heard that. I made a note. I will look it up and give you an answer, but I think it is something to consider. I know that the calculation of 30 to 50 cc's an hour is based off of 0.5 to 1.
I found that I mentioned about that urine higher than 0.5 milliliter per kilogram per hour indicates over-resuscitation in sepsis management in prolonged field care, updated in 2023, page number 9.
Okay.
And the second question, do you think is it reasonable to use as well urinalysis for monitoring of the hydration status of the patient? In this case, I mean in burn management.
I hadn't thought of that. So if you're looking like specific gravity?
Yeah, that's what I'm talking.
Yeah, creatinine, sorry. Well, that's a good point. I mean, we have urine dipsticks.
Yeah, because I try to do that in prolonged field care environment. And I measure urinalysis not super often, like once, 2 every 3 hours. And it gives me also good idea together with the urine output, because again, in the end of the story, sometimes when you work on the field, it's not always possible to monitor urine, but it's much easier to get urine and put dipstick and see what is the hydration status. But I didn't find any really reliable studies who say
it's good or it's bad. Maybe someone has another experience.
Dimitri, I had a look as well when we were doing one of the modules, and I spent hours looking to see if any of the measurements on the urine dipstick could be used for a reliable assessment tool, like continuously, especially in like electrolytes and like fluid status. Just same as you, I couldn't find anything that was even worth carrying the dipsticks for. Even glucose was rough. Like even in KCMC, they would use it to determine DKA versus HHS, and all of those measures were also just like disappointingly inaccurate. So I would love for it to be the case, but I didn't find anything either.
No, great points. Aebhric, can you jump to the infection slide? I'm looking at the time we have. Yeah. So protecting the patient's extremities and their torso from infection. Part of that is going to be putting clean sheets and dry gauze on them. You know, you leave the blisters intact. You want to avoid wet dressings. You're going to put that on there. And then when you go to debride, that is actually the infection control, because all of that, the crust and scabs that's formed are going to be debrided when you take off the bandage and change off your bandages. So it's not recommended to give prophylactic antibiotics, which I think is the next slide, in a burn patient, because of this cleaning, for this debriding and cleaning process. That's the part that keeps it. You're doing the gentle scrubbing with chlorhexidine and gauze. Obviously, you have pain control for this. You do not want your patient to be awake to experience this. If you have the ability to kind of put them to sleep a little bit, do it for procedural. This is a procedure. It is painful. And then repackage the wound and repeat. Yeah, go ahead, Tanguy. You got a question?
I'm sorry, I'm so jumping the gun a little bit. I've had way more pediatric burns than adult burns, and especially very young children. And I was wondering if you guys had any advice about how to hold a child, especially with like massive, like systemic burns, because they get super slippery. They're in so much pain, and they don't understand like an adult. If I stop doing this behavior, I will have less pain. They just freaked out. And, you know, part of my concern is, you know, if they're moving, they're exposing themselves to more infection risks. And me also grabbing them and touching more surface area is also an issue. I don't know if you guys have found any techniques other than just massive sedation.
Have you got access on your truck to stuff like the Blizzard survival blankets, any of the hypothermia wraps, Tanguy?
I tried, and I really wanted to swaddle them, but the slipperiness is just unbelievable. I would have preferred a bag that I could, you know, sort of put it over.
Yeah, it's tough. Now, kids are always difficult, no matter whatever the trauma or the insult is. But yeah, securing them, first and foremost, I would say some type of sedation to get them to calm down, and then use the same like gauze bandage. Like you have gloves on and use gauze, and the gauze will add some texture to the extremities. And then obviously the size of the patient, you know, you can have a 9-year-old that's bigger than I am, but you know, you have to figure out, you know, what's the appropriateness for this. And if you need more people, you need more people. Obviously you want to have somebody that can talk to the patient and calm them down, you know, psychological safety for them to communicate. They're not going to like it at all, but yeah, your imagination is your limits. Yeah. And the goal of this, the so what of infection control, is doing it through your normal wound care process. And that's cleaning and debriding the wound, covering and protecting it, and rinse and repeat. That's, you know, with the appropriate pain control during the changes. Antibiotics, no prophylaxis for this unless there is concomitant trauma. If there's a blast injury trauma with a burn, you're giving antibiotics for the battlefield antibiotic protocol that you're going to give. If it's isolated burns, just like hot water, oil, some type of fire, whatever it is, all of that, the infection control is the means of preventing. You know, your wound maintenance is the means of preventing infection. Antibiotics prophylactically are not indicated. If you do, they want you to go ahead and treat for gram-positive because of the surface area that are burned. Watching secondary infections showed up during the healing process and the debriding process, that's obviously where a lot of that's going to take place, and how clean the environment is and how frequently you're able to change dressings. I mean, if you do, they want you to treat with broad spectrum antibiotics. Does anybody have a favorite? Cool. Andre?
Yeah, I was just wondering, like, if in this case, as a choice for antibiotics, cephalosporins, third generation, like ceftriaxone or something, would be indicated, or?
Yeah, that would cover your gram-positives, and they're broad, relatively broad. I think it depends on, if you have the benefit of using an antibiogram and to know what what antibiotics work best in regions, because it does change depending on where you are and how frequently they use them. One of the benefits of being in some remote areas of the world that we work in is that they don't have typical overuse of antibiotics. So some of the basic antibiotics that we can no longer use in America a lot of times because of overuse and resistance, they don't really have that same problem in some of the remoter areas that we work in. But I would look at the specific areas that you're going and see if there's anything that's contraindicated. Yeah, cool. Any other comments? Heard of Penham? Yep. All right. Aebhric, you had the burn guide in here. I think this is a great visual representation. I think it's important to know that 3rd degree burns are rarely, they're like little islands, like lily pads, if you will. There's going to be some areas of 2nd degree or partial thickness burns surrounding the full thickness. Full thickness doesn't hurt because everything in the dermis is completely nuked. It's full thickness, so that kills all of the pain receptors and the processes that would be causing the pain. Rarely does it cover everything universally, so you're going to have partial thickness, which are very painful, interspersed with the full thickness. And when you get to something like doing a procedure like an escharotomy, you really have to be selective about how you cut through the skin, and you're only going to cut through the full thickness or 3rd degree portions of that to prevent the skin tourniquet from restricting flow. And that's more art than science. I mean, you have to have a really good idea of what's going on with the thickness and how you can feel it tactily, what feels like a full thickness versus partial thickness, and your patient's response. And that's a mixed bag too, because when you're going to do a procedure like an escharotomy, you want your patient to be sedated. And so it's kind of hard for them to give you an accurate representation of what hurts and what doesn't hurt before you do this procedure. Any suggestions or history? I've not worked in a burn center to find, what's the common practice in there. And I've not done an escharotomy on a real patient. Any experience in the group that is open to sharing? Cool. Just realize that those are complications, something you should worry about. Aebhric and Rhod and I talked beforehand. We're going to split this one. We split this one up and cover sepsis. Obviously, we would not have been able to do both of these topics justice by cramming them into one session. I think I like this format better when we add more interaction. And so next month we'll do sepsis and take your inputs for topics beyond that. Leo, Dimitri.
Yeah, I got a question regarding the pain management. During the year 2 BSc program, we have nice module burns in resources limited environments. And there I found recommendation regarding using the topical morphine in context of burn management, pain management. So I used that twice and it worked perfect in the context of pain management. But before and after, I tried to find some researchers, and because it's this kind of pain management using the topical morphine is not in the guidelines, I just guessing, has anyone had experience using the topical morphine in the context of burn management, and what is your impression of its effectiveness and safety? Thank you.
I have not used topical morphine.
Yeah, one of the founders of the college, Dr. Winston DeMello, has been using that. He's an anesthetic doc, burn specialist doc, and he has been using topical morphine successfully for about 15 years. And it just does the pain management without getting into hemodynamic changes. So you put a vial of morphine into sterile water and you spray it on, and it works really, really well.
Yeah, okay, thank you. But I just read a couple of researches about that. It works perfect regarding the pain management, but there are some considerations regarding the wound healing in the future using the morphine on that way. So that was my primary concern. But treating the pain, I did the same as you say, and it works. It works perfect, and it decreased the number of medications I use intravenously for the patient.
Love it. Learn something. I like that, Aebhric.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.